Acute pancreatitis. NB. Diseases of the pancreas provide an enormous challenge to the clinician, and although patients with the more common forms of pancreatic disease, i.e. acute pancreatitis and pancreatic carcinoma, have historically been managed by surgical teams, there is a growing trend for non-surgical, i.e. medical, management. Etiology, pathophysiology, and pathology. This is an acute inflammatory process of the pancreas with variable involvement of other regional tissues or remote organ systems. Once the process has started, the degree of pancreatic necrosis is variable and in part related to proteolytic autodigestion of the gland. The most common causes of acute pancreatitis in the UK are gallstones, 30–50%, and alcohol, 10–40%, but a significant number of cases do not have an immediately obvious cause, 15%. NB. In the absence of gallstones or alcohol, consider the following rare causes of acute pancreatitis before making an idiopathic diagnosis. Drugs, steroids, azathioprine, sulfasalazine, furosemide. Pancreas divissum, congenital malfusion of the dorsal and ventral pancreatic buds. Sphincter of Oddi dysfunction, high-pressure sphincter causing duct hypertension. Hypertriglyceridemia, may be associated with alcohol abuse or diabetes. Hypercalcemia and hyperparathyroidism. Viral, mumps, Coxsackie virus B, Epstein-Barr virus, cytomegalovirus. Hereditary pancreatitis. Hypothermia, Ruhr-Meng injury to the pancreas. Clinical presentation. Common. Abdominal pain, usually epigastric, and radiating through to the back. Vomiting. Hypovolemia, circulatory collapse, hypoxia. Uncommon. Jaundice suggests the presence of an associated cholangitis and raises the probability of gallstones. Rare. No pain, consider hypothermia. Physical signs. Common. In mild acute pancreatitis there may be few physical signs. Otherwise expect abdominal and epigastric tenderness or infrequent or absent bowel sounds. Uncommon. In patients with more severe disease there will be clinical evidence of hypovolemia and systemic inflammation. Other features may include mental state, the patient may be agitated and delirious. Tachycardia. Hypotension. Fever. Peripheral cyanosis. Peritonism. Rare. Cullen's sign, periumbilical bruising, and Gray-Turner's sign, flank bruising, are both associated with severe hemorrhagic pancreatitis. Investigation and staging. Diagnosis with serum amylase. Serum amylase is diagnostic of pancreatitis if more than 3 times the upper limit of normal for the laboratory. Alternatives include serum lipase and possibly urinary trypsinogen. Assessment of severity. Severity can be assessed using the Glasgow and Ranson criteria. NB. Glasgow and Ranson criteria. 3 or more positive criteria, based on initial admission score and subsequent repeat tests over 48 hours, constitutes a severe disease. Age greater than 55 years. White blood cell count greater than 15 × 10⁹L. Glucose greater than 10 mol/L. Urea greater than 16 mol/L. PaO2 less than 8 kPa, 60 mmHg. Calcium less than 2 mol/L. Albumin less than 32 g/L. Lactate dehydrogenase greater than 600 U/L. Aspartate and alanine aminotransferase greater than 100 U/L. The Acute Physiology and Chronic Health Evaluation, Apache 2, scoring system is used in many intensive care units. An Apache 2 score of 9 or more is considered to constitute a severe attack of acute pancreatitis. A peak C-reactive protein level greater than 210 mg/L in the first 4 days of the attack, or greater than 120 mg/L at the end of the first week, indicates severe disease. Assessment of cause. An abdominal ultrasound should be performed within 24 hours of admission. This will determine whether there are gallstones present and may demonstrate biliary dilatation, suggesting common bile duct obstruction. Assessment for complications. Depending on the method of presentation, some patients will undergo abdominal CT as their first imaging investigation to exclude other causes of acute abdomen. A CT with contrast should be performed in cases of severe pancreatitis between 3 and 10 days after admission. In addition to identifying secondary complications such as pseudocyst formation, Fig 34, the extent of pancreatic necrosis carries prognostic value, Table 34. Differential diagnosis. This includes perforated peptic ulcer, intestinal ischemia, and infarction, ectopic pregnancy, aortic dissection, myocardial infarction. Treatment. Emergency. Resuscitation. Intravenous fluids to restore circulating volume, may require central venous pressure monitoring, and oxygen. Patients with severe pancreatitis, as defined above, should be managed in either a high-dependency unit or an intensive care unit. Analgesia. The pain of acute pancreatitis is usually intense and requires opiate analgesia. Pethidine is usually used because it has less effect on the sphincter of Oddi than morphine. Nutrition. Although historically patients with acute pancreatitis were fasted with gastric aspiration, drip and suck, early nasojejunal feeding is now favored once vomiting has settled. Antibiotics. Use of blind broad-spectrum antibiotics is controversial, although recent studies have suggested a reduction in septic complications. Antibiotics should be used in cases of proven infection or organ failure, with the third-generation cephalosporin generally recommended. Short-term. Endoscopic retrograde cholangiopancreatography, ERCP. If gallstones are present on ultrasound or if the patient has clinical features of cholangitis, fever, jaundice, early ERCP, i.e. within the first 24 hours, should be considered on the principle that early relief of biliary obstruction will reduce complications. If this is not performed within 24-48 hours, edema of the papilla makes ERCP technically difficult. ERCP can also be employed in pseudocyst drainage if there is communication with the pancreatic duct. Endoscopic ultrasound, EUS. The advent of EUS has enhanced endoscopic interventions for pancreatic disease. A pseudocyst that does not resolve spontaneously within 6 weeks usually needs draining to prevent complications, infection, rupture, or bleeding. This can be done into the stomach using EUS guidance, which identifies a suitable tissue plane and helps avoid vessels in the area, Fig 35. EUS may also reveal a cause for acute pancreatitis that cannot be identified by other imaging modalities, e.g. microlithiasis, small tumors, or cysts. Other. Surgery may be indicated in cases of infected necrosis. Pancreatic abscess may require CT-guided drainage. Long-term. Management of the appropriate risk factor helps to prevent recurrent attacks. Abstinence from alcohol. Early cholecystectomy if gallstones are confirmed to be the underlying cause. Control lipids, calcium. Complications. Common. Pancreatic pseudocyst abscess. 5% persistent pain and/or fever suggests the development of a pancreatic pseudocyst or abscess, as does a persistently raised amylase. Paralytic ileus. Hypovolemic shock. Renal failure. Hypocalcemia. Hypoxia. Uncommon. Portal vein and mesenteric thrombosis. Adult respiratory distress syndrome. Ascites. NB. Ascites due to pancreatitis has a high amylase content. Rare. External pancreatic fistulae may follow percutaneous drainage of pseudocyst. Prognosis. 30% of patients have recurrent attacks, which are more likely in pancreatitis related to alcohol consumption. Overall prognosis may be worse in idiopathic pancreatitis. Morbidity and mortality. This depends on the severity of the attack. Table 35. Prevention. Primary. Other than a reduction in alcohol consumption, there is little scope for primary prevention of acute pancreatitis. Secondary. Cholecystectomy. Abstinence from alcohol. Management of risk factors.